Dr. Rogers?
Let's do it, Dr. Ambach.
Right. Good afternoon, everyone. Thank you for joining us in our Ask the Docs session. For those of you who are joining us for the first time, this is a 30-minute question and answer session where Dr. Rogers and I devote our time to answer questions from the public or from our patients or whoever is interested to learn more about different orthopedic conditions and innovative therapies on how to treat these conditions. So every session we do have a special topic, and that way we can focus all our questions on the topic. And our topic for today is Achilles tendon injuries, whether that's Achilles tendinopathy or Achilles tendinitis or Achilles tear. You can ask us questions about this condition, treatments, symptoms, contraindications to treatment, risk factors. Feel free to type in your questions. If you are joining us through Zoom, there is a Q&A button at the bottom of your screen and you can start typing your questions. And if you're joining us through Facebook, you can write your questions in the comment sections. So I'm very happy today because Dr. Rogers is joining me since last month. He missed last month's session, but now he's joining me. So I feel complete.
Well, I'm very glad to be back as well, doing the things that we love to do. Turns out doctors are human, just like everybody else, and we have injuries. I had a particularly nasty injury, but I'm happy to say I'm on the mend. Applying all our rehab, regenerative medicine knowledge to my own self, and I get to learn again what it's like to be a patient. So I think we'll come out of this experience a little bit better than when we started. But definitely glad to be back here talking about the Achilles tendon, which is something that we see not too infrequently in our office. As you know, the Achilles tendon is the tendon in your ankle. It's actually the largest tendon. It's named after the Greek god Achilles. There aren't too many tendons named after Greek gods, Dr. Ambach.
Yeah.
Of course, Achilles, his mother, being the typical worrying Greek mother, his mother worried about him being vulnerable to arrows and things, and so she dipped him in the river Styx so that he would be invincible. Unfortunately, she was holding him by his ankle, and so that was his weak spot. Us mere mortals have lots of weak spots, turns out. The Achilles tendon is just one of them. But it is the largest tendon in the body. It attaches to your heel bone and to your calf muscles. And it's what gives you the ability to run and jump and climb upstairs and do all these things. And of course, it's just like any other tendon, is susceptible to injury. So we'll talk about how we treat those injuries.
Right. So Dr. Rogers talked about different injuries to the Achilles tendon. And you probably heard us throw out some different terms or different terms from your physicians. So there's Achilles tendinitis, and then there's Achilles tendinopathy or tendinosis. And basically the difference between these two is when they say tendinosis or tendinopathy, it refers to a chronic wear and tear pattern of injury into your tendon, wherein your tendons get worn out, they get thickened over time, they get inflamed. Your normal tendon loses the collagen, the normal collagen architecture, and it just becomes painful in the process. When you hear Achilles tendinitis, it doesn't necessarily refer to a chronic injury. It's really mainly an inflammation or soreness around the tendon itself. So there's a difference between the two. Most of the conditions that we see in the clinic are the tendinosis or the tendinopathy conditions, because whenever you injure your Achilles, usually you start doing your own treatments at home, and most of the time it does get better, and when it doesn't get better, that's the time that you come see us. So Dr. Rogers, can you give us some risk factors for developing tendon injuries, whether it's inflammation or tear or tendinosis?
Yeah, it's the same general principle as is true for most tendons. So overuse, so our jumpers, our volleyball players, our runners, They are putting more load on the tendon, therefore there may be more micro trauma. Over time, that micro trauma can evolve into a larger tear. Abnormal biomechanics, so people that have an arch that's too high in their foot or an arch that's too flat in their foot, who have altered biomechanics of the foot and ankle, can be at risk. People that are obese, people that do not have ideal body weight, are putting extra load on that tendon. Those are some of the common things we see. In addition, this tendon is a little different than other tendons, particularly where it attaches at the heel. Instead of the fibers coming into the bone and attaching perpendicular to the tendon, they actually sort of wrap around the heel. And so they're at a little bit of a 90-degree angle, which puts extra stress right at that attachment point, what we call insertional tendinopathy. And strangely enough, that force induces tendon cells to become calcified, to actually become mineralized. And that can be really difficult to treat when you've developed mineral deposits. Some people call it a bone spur or a heel spur. In reality, it's calcification of the tendon, and those are particularly nasty to treat.
Right. I have patients that have flat feet, and they asked me, is flat feet a risk factor for developing Achilles tendon injuries? And yes, it does. You know, as Dr. Rogers said, anything that affects that normal biomechanics and how you load that tendon can affect it, whether you have, you know, scoliosis or knee joint or osteoarthritis. That can change the way that you set your feet down to the ground, and it can increase the load in your tendon. Also, patients who have abnormal motion into their joints can also have are also at increased risk for this, or patients who have weakness in their what we call plantar flexion when you put your feet down to the ground, either from stroke or a sciatica or back problems. Whenever you've got that weakness, it puts a lot of pressure into that tendon as well. So other things that may present in the same way as an Achilles tendon problem would be one is bursitis. There is a bursa. I know we talked about bursitis in our other webinar sessions. The bursa is a sac that comes in between your soft tissue and your bone, and it acts like a cushion to protect these two structures. And there's multiple bursa right around where your Achilles tendon inserts to your heel bone. And when that gets inflamed, you can have a bursitis. They feel the same way like an Achilles tendinitis or a tendon injury. What other conditions can you think of, Dr. Roger, that presents the same way as an Achilles tendon problem?
With heel pain, well, usually with Achilles tendon injuries, the pain is pretty local to the tendon, and the tendon's really easy to palpate. You can just grab the back of the heel and feel that tendon pretty easily. There are other things that might refer pain to that area, like you mentioned before, sciatica, although that's not typical. Sciatica doesn't often refer to the back of the heel, although I have seen cases, particularly if you have a herniated disc at L5-S1 and you have an irritated S1 nerve root, some patients may feel pain in the back of their heel or the side of their foot. But you know, fractures, of course, you know, if the bone were fractured, some people have a bone spur on the back of their heel bone, something called an Haglund's deformity.
That's right.
That can irritate those soft tissues, the bursa, as you mentioned, and the tendon itself. There's also a fat pad. So, you know, we think of fat as a bad thing, but a lot of our tendons and joints are surrounded by fat, which sort of cushions these tissues and probably is a source of stem cells for a lot of these joint tissues, because we know that there are stem cells in fat tissue. And so, but you can get an inflammation of the fat pad itself, probably from biomechanical stress to that tissue.
Right. So how do you diagnose Achilles tendon injuries? There's several ways. The first step is for us to get a good medical history and a physical examination. As Dr. Rogers mentioned, it's pretty obvious what the where the pain is coming from when you have Achilles tendon problems, because usually the tendon is swollen. There's a node right where your tendon is, and when we press on the tendon, it elicits a familiar pain. There's a swelling, there's tightness in your Achilles, and sometimes that can create weakness. Actually, some athletes, usually that's one of their initial symptom is the weakness in their legs or decrease in their performance, even before they know that they have an Achilles tendon injury. That's usually their initial presentation. So after we have the clinical suspicion of the diagnosis, we have an ultrasound machine in the clinic, which is a really good tool on how we can look at injuries in your body. And we can see tendons really nicely on ultrasound, and we can see the tears, we can see thickening, we can see inflammation. So it makes it really easy now to diagnose Achilles tendon injuries with a visual objective finding, and not have to get you to go get an MRI of your foot.
Yeah, and there's good evidence that the ultrasound is more sensitive and more specific than MRI. Not only is it easier to do, but it's an actually more accurate way of imaging those tissues, and it's very satisfying. I mean, we answer the question within 5 minutes. We can tell the patient exactly which tissues are injured and to what degree, because the degree of severity influences what kind of treatment we're going to recommend. For example, if you have a very small tear or a little bit of swelling, we're going to treat that completely differently than someone who's completely torn through their tendon. Matter of fact, we as non-surgeons probably will not treat a full thickness tear. If the tendon is completely cut across so that the fibers are no longer communicating, that is a very difficult thing to heal without surgery. And who knows, maybe in the future that will be different, you know, with some of the new technology that's being developed. But currently, that's the status. So right off the bat on that first visit with the patient, we can get them started on the appropriate treatment and, you know, and know what our outcomes are going to be.
So what should I do first to treat my Achilles tendon if I present with this problem? There's several things that you can do whenever you start seeing that bump or that swelling in your Achilles tendon. First is to modify your activity. You're probably not going to be able to do your running or your jumping anyways if that Achilles tendon is hurting, but try to limit load on it initially. Some anti-inflammatories can help. There is now over-the-counter topical anti-inflammatories that can help if there's too much swelling into that tendon. By the time you see us, we start talking to you about strengthening the tendon, strengthening the support muscles, and getting you to start a course of physical therapy or rehab. And that's really the main treatment for these injuries. Don't you agree, Dr. Rogers?
Yeah, I do agree. And physical therapy, of course, encompasses a wide range of activity levels, everything from very simple stretching and massaging of the tissue for a very acute, sensitive tissue, all the way to getting you to jump up and down on a trampoline to, you know, develop that eccentric strength of the muscle. So it's very important that we diagnose the injury appropriately so we can plug you into the rehab program on that continuum at the right level, so that we're not overloading a tissue that's not ready for that injury yet. At the same time, we're stimulating the tissue to heal at the appropriate level.
That's right. So physical therapy will probably take you anywhere from 4 to 6 weeks, depending on your progress. There are other adjuncts that can help. You know, some physical therapists like to tape that area. They call it kinesiotaping. And sometimes that can reduce the strain on the tendon. There's also heel lifts. When you put a heel lift, that can decrease the irritation between the tendon and the insertion in the bone. And sometimes those can help. When patients come into the clinic, some of them have figured these things out, and they come in with an orthotic, you know, that lifts their heel to make it feel better. So those are the things that you can do at home. I get questions a lot about laser and shockwave therapy. What can you say about that, Dr. Rogers?
There is some pretty good data on shock wave therapy. Again, without, I don't want to get into the weeds too much, but there are different types of shock wave therapy. So just like not all physical therapy is the same and not all PRP is the same, but not all shock wave therapy is the same and not all laser therapies are the same. And so for certain types of shock wave therapy, which is basically a device that delivers a little impulse, a very strong sound wave to the tissue, there's some evidence that it does stimulate healing in the tissue. And this is something that we've investigated. We don't use a lot of now. It's not really mainstream in healthcare, but the preliminary data is looking very good. There's also some evidence that laser is helpful for tissue healing. Of course, it has to be the right kind of laser. They all come in different wavelengths. Some of them can penetrate very deeply, others do not. The Achilles tendon is a pretty superficial structure, so assuming that the leg is not, a large leg, laser should be able to penetrate that tissue, and I think it's worth doing. I'm not sure if insurance pays for laser therapy or shockwave therapy. I don't think they do.
No, yeah.
But there are some physical therapy clinics that offer it to their patients. Some of our podiatry friends, the podiatrists, they have it in their office. But there is good evidence to suggest that these things may be helpful in speeding up the healing process.
This therapists are also multi-session therapists. Usually you have to go to the clinic many times, 4 to 5 times, every week or every 2 weeks to get the results from these therapies.
That's right.
What about steroid injection into the Achilles? So
Yeah.
I'm sorry, Dr. Rogers.
Yeah. Oh, I thought you were asking me. Yeah. Well, generally speaking, we're injecting steroids fewer and fewer times. And that's because the evidence is showing that they probably are not very effective. And equally important, they might not be safe for the tendon. We know that if you put a tendon in steroid, that tendon cell will be killed. Maybe very low doses of steroid may be helpful if there really is inflammation. But like you said, most of the time we're dealing with chronic degenerative changes of a tendon. We're not really talking about true tendon inflammation or tendinitis. The tendon may be swollen, but it's not swollen because the immune system is attacking it. It's swollen because the damaged tissue is weeping fluid, much like a blister would weep fluid. So steroids don't really help that. Ice and massage and exercise might be more effective for that. If there's a true inflammatory condition, steroids may be useful, but I don't find myself injecting tendons with steroids. Occasionally, if we have a bursa that's inflamed, we'll inject a small dose of steroids in there, but less and less, I would say, than certainly in the last decade before.
I completely agree. We don't like to inject steroids into the tendon because it makes it more prone for tendon rupture. We don't want to injure the tendon. There's another procedure that's called hydrodissection. And basically, that's just a fancy term to mean that we're putting fluid around the tendon to help release scar tissue that may have tethered your tendon and limited its normal movement or normal range of motion. So sometimes that's helpful for patients who've got really, really tight Achilles. We can see some scarring behind that tendon, and usually using fluid to dissect or take away the scarring around the tendon helps as well.
And that's where the ultrasound, sorry to interrupt you, but that's where the ultrasound helps us. We can move the ankle up and down. We can see the Achilles tendon sliding. And if tissues are sticking, like again, that fat pad, if it's sticking to the tendon, we can see that. If the fat pad looks like it's thick and scarred versus normal healthy fat, we can see that, and that can help us again determine whether or not that treatment's necessary.
That's right. So how can cell therapy like PRP or cell therapy from fat, adipose, or bone marrow help with tendon injuries? It used to be that when patients fail standard treatments, their only other option is to do surgery. And for this condition, there's several things that they do when they do surgery. Either they shave off the bone that's irritating the tendon, or what they call a bone excision, or they do a bursectomy. Sometimes they take out all the bursa that's around that tendon, or sometimes they do a tendon transfer, wherein they use the other tendons from around the foot and ankle and use it to support the tendon. This could be very involved surgeries in some cases. We see these patients in our clinic. Sometimes they end up with more pain. So it's good. Within the past 10, 15 years, now we have these regenerative therapies, or what we call cell therapies, that bridges that gap between standard treatments and surgical interventions to be able to treat the conditions non-surgically, and to actually encourage and promote healing instead of just masking the pain. So, Dr. Rogers, want to tell me how PRP can help with the Achilles tendon
Yeah,
injury?
yeah. I would answer the question from three distinct perspectives. The first perspective is, how does PRP in general affect tendon cells? We have some good basic animal data that shows that the growth factors released by the PRP, the platelet-rich plasma, does improve the tendon's ability to function, does improve the tendon cells' ability to grow and multiply, to produce collagen fibers, to inhibit inflammation, all the things that have been shown to be helpful for tendon healing. Now, those are basic science studies, so that's one perspective. The next perspective is, what happens when we do a clinical study where one group gets PRP injected in their tendon and the other group gets some placebo, say water or steroid or something injected into their tendon? I would say the data right now, if you were to go look at the scientific studies, is very mixed. Some of the studies show it's helpful, some of the studies show it's not helpful. Why would there be that discrepancy? Well, this is an art, it's not just a science. And so each of those studies uses a different kind of PRP. The platelet concentration may vary, the white cell concentration may vary, and the patients that they're treating may vary. One study may look at very mild cases, another study may look at very severe cases. So we're not yet at a point where we have a number of clinical studies that tells us, oh, if your condition is this severe, if it's mild or moderate, then your success rate will be 80% or 90%. We don't have that data yet. So the data is very early, but it's too early to say that PRP works, and it's too early to say that PRP does not work. The third level of evidence we have is our own patients, the people that we've been treating for the past 12 years, injecting cells into tendons, into patients who previously were not treatable, who had done all the standard treatments, and now we're still dealing with this problem. And in many of those cases, we've been able to show that they were able to improve. Not only did their function improve and their pain improve, but we could see the changes on the ultrasound and on the MRI. The first case I ever saw, we're talking about PRP, but we could also talk about cells from fat or cells from bone marrow. I had a patient, 16-year-old patient, who for 2 years, she was wearing a boot because she had a very severe Achilles tendon injury. The boot that immobilizes your ankle, not nice boots, but a cam walker boot. And she was an athlete, and she had not been able to perform in her sport, basketball. And when I looked at her tendon under ultrasound, it just looked like Swiss cheese. There were holes everywhere throughout that tendon. It wasn't like the tendon had just ripped in two. It just was so degenerated that it had all these defects over a span of about 5 or 6 centimeters. I knew that PRP probably would not be strong enough for this injury based on my experience, so we elected to take cells from her fat. And in 3 months, we filled in all those holes, all those tendon defects healed, and she was able to remove the boot and run on the beach for the first time in 2 years without pain. So that was anecdotal evidence, but significant anecdotal evidence, where I have a patient who now can run, whereas before she could barely walk without a boot. She has no pain, whereas before she had pain all the time. And the ultrasound image looked better, and the MRI image looked better 3 months after we treated her. So to me, that was evidence that in that patient, we had made a difference using cell therapy. I would like to see studies where they do more of that kind of work and see if that's the norm. Was she an outlier, or is that something that the majority of patients would respond? We need to collect that data.
That's right. We have a lot of nice before and after pictures of tendon injuries that we've treated with our patients, and we're collecting them, and hopefully we can, publish them soon. But yeah, for us, if we see these results in our patients, and it just makes us more inclined to recommend this as a treatment, especially if it can prevent surgery in these cases. I also wanted to add with what you said regarding all these different studies, why they have different results is that the injection manner or protocols are also different. And we were just talking about ultrasound, wherein when we do our procedures, we have to know exactly where we're going. We have to know exactly where the tear is or where we want to deliver the cells. And I think that's very important when you seek someone who would do your procedures, is to make sure that they use guidance, either X-ray guidance or ultrasound guidance. In the case of tendon injuries, ultrasound is usually the best imaging modality for us to see the injuries and guide us to the procedures.
To your point, I have another quick story, and you're absolutely right. The ultrasound helps us to perform the procedure, not just for effectiveness and safety, but also for comfort. I had a patient, a nice gal, who had a very bad tear in her Achilles tendon, and she had received PRP at another clinic in San Diego. And she said it was the worst experience she ever had. It was extremely painful. And then when I recommended that, and by the way, it didn't work, it didn't help her. But when I looked at her tendon on ultrasound, I thought I could help her. And I said, I think we should do the PRP differently, but do it again. And she was very scared because she had had such a bad experience. I asked her to trust me. And she did. And later we did the procedure. And as I'm treating her Achilles tendon, and I said, we're almost done, she started crying. And I said, oh, I'm sorry. Am I hurting you? Why are you crying? She goes, no, I have no pain. It was so much worse with the other procedure. And I'm sorry that I even had to go through that experience. So there definitely is a way to make it safer, more effective, and more comfortable. And the Achilles tendon, in my experience, is one of the more comfortable procedures that we do. Patients tolerate it very well.
That's right.
And I think the technique that we've developed is a good one.
Yeah. So we talk about PRP. What is the evidence for cell-based therapy? I know of one study that used bone marrow concentrates and bone marrow-derived cells for Achilles tendons that has been recalcitrant to treatment. So these patients that they have enrolled in the study had Achilles tendon crowns for more than a year. And after one injection of the bone marrow cells, patients did really well. They followed them up to 6 months. That was the length of the study, and patients did really well. I'm not aware of any fat-derived cell studies. Dr. Rogers, are you aware?
There's one. There's one published study out of Italy where they compared PRP to something called SVF, which is a form of fat-derived stem cell.
That's right.
Which is not legal in the United States currently. But there is evidence that it was effective. What they found is that both the PRP group and the fat-derived stem cell, the SVF group, both did very well, but the stem cell group healed more quickly. Patients achieved much greater relief of pain and improvement in function at about 2 months, whereas the PRP group took about 4 or 5 months.
Wow, it's already 1 o'clock. The 30 minutes went by so fast. I hope you learned something about Achilles tendon injuries today. We discussed what the symptoms are. We discussed what causes it, what are the risk factors, what are your options for treatment, and know that there are options that are non-surgical that are effective in treating these conditions. As I said in the beginning, we do this question and answer sessions every first Wednesday of the month. So we'll see you again next, September, and see you on the first Wednesday to discuss another topic. And then we also have more detailed webinars wherein we have lectures and slides about specific topics. And we also do that every month. So watch out for our Facebook posts or on your emails on when our next session is going to be. I'm really glad to see you, Dr. Rogers. I'm sure our patients are really glad to see you. Any last words for our patients before we go?
Take care of yourself. Be healthy.
All right, till next session. Bye, everyone. Thanks for joining us.
Thank you. See you next time.
Bye.